and its clinical implications in our memory disorders clinic at VA Boston. So the outline of the talk, first I'll talk about what amyloid PET scans are and how they're currently used, and then talk about two of our projects related to clinical use of amyloid PET scans. So the first was just about ordering practices among clinicians in our clinic. And the second was what are the clinical and management implications resulting from these studies. So just to review, Alzheimer's disease is thought to result from a cascade of different pathophysiological events. So the first is thought to be the accumulation of amyloid beta, which can be measured either in the CSF or using PET scans like amyloid PET scans. And that's represented by this red line here that is thought to be the first thing sort of happening in a patient's life. And oftentimes it's not detected until many years later when some of these downstream markers start to occur. So the second event we think may occur is synaptic dysfunction between neurons or signaling difficulties that might be measured by some other, using some other techniques. Another type of PET scan called an FDG PET scan can look not at amyloid, but more at glucose uptake and metabolism. And functional MRI studies could also be used to look at this orange line. And finally, EEG or event-related potentials could be another way to look at this downstream marker. Following this, we think that there's tau-mediated neuronal injury, which we hope we'll be able to measure using tau PET in the near future clinically. It's definitely being in the research realm now. And then CSF measures of tau could also give us some measures for this green line. Much later downstream in a patient's experience, they'll also have brain structural changes in terms of volume and atrophy on their magnetic resonance imaging. And then very late in the disease stage, they'll have cognitive changes in terms of their testing profile and neuropsychological testing. And the latest of all will be changes in clinical function. So typically these purple and brown lines are when we're finally seeing a patient in clinical practice, but there are all these upstream things that probably happened decades earlier. So currently there are two kinds of classic classes of Alzheimer's disease biomarkers. The first are CSF markers, which can be reliable. We look for decreased amyloid levels and increased tau levels. The tau levels are relatively non-specific for Alzheimer's disease and can happen, increases can happen in many neurodegenerative conditions. The downside here is that this is an invasive technique that not all patients want to undergo. And so alternatively, there are PET images, which can sometimes give us a lot of the same information. So we're going to be talking primarily about amyloid PET imaging, which is FDA approved and has been for years. There are some pluses and minuses of these techniques. So they can be relatively non-specific in older adults, and that we think a lot of older adults tend to accumulate amyloid as they age. So in the setting of a cognitively normal person who has a positive PET scan, it can be hard clinically to know what to do with that situation. So you typically want to get these studies in people who have some cognitive deficit to help interpretation. They're also expensive. They do involve radiation exposure. And one downside is that they're not currently reimbursed by insurance. So it's not easy to get these studies clinically, and they're limited mainly to the research realm for the most part. So currently there are amyloid PET appropriate use criteria that have been around for a while. And these are the groups of patients we want to consider ordering an amyloid PET and if they're available. So there has to be a cognitive complaint or some objectively confirmed impairment on neuropsychological testing. And then Alzheimer's disease has to be in the differential if we're considering ordering these scans. And that's the case after they've been seen by a dementia expert. And then we also have to think that getting this scan is going to change our diagnostic certainty or alter management in some way that's clinically actionable. So the ideal candidates for a scan like this are patients who have persistent or progressive or unexplained mild cognitive impairment, which is a precursor stage to dementia. So they don't yet have functional limitations, but maybe they're testing in an impaired range on neuropsychological measures. The other group would be those who have possible Alzheimer's disease, but have an unclear or atypical presentation. And when we think there might be mixed etiologies, so Alzheimer's disease with Lewy body or Alzheimer's with vascular disease, for example. And then finally, any patient who has progressive dementia and an atypical or early onset before age 65 would automatically meet criteria for amyloid PET according to these 2013 guidelines. They also specified when you might not want to get an amyloid PET. So patients who have a classic case of Alzheimer's disease with the typical age of onset after age 65 probably wouldn't change management to get one of these studies. You don't want to get a study like this to determine dementia severity. There's no correlation between amount of amyloid load and clinical function or neuropsychological testing. And these studies are not helpful to screen when there's a positive family history of dementia or there's a presence of ApoE4 that the patient is concerned about. And then if the cognitive complaint is unconfirmed by neuropsychological testing or exam, the next best step is not to order these scans. They're not useful in place of genotyping, and they are not useful typically in asymptomatic individuals. And then finally, we don't want to use them in legal insurance coverage questions or employment screening issues. So our clinic represented a special sort of opportunity to study amyloid PET use, in that just to review, these studies are FDA approved, but unfortunately not currently reimbursed by insurance. So in the private healthcare setting, most neurologists are not able to order these scans for their patients, but we are at the VA because we don't have to worry about reimbursement by insurance. So there had been no prior studies of real-life ordering practices or implications of amyloid PET ordering within a clinical practice in the US. That was what we were hoping to add to the field with this first study. So our initial aims for this first study were just to look at the rates of adherence to the appropriate use criteria. And we suspected and hoped that our appropriate use criteria rates would be relatively high among the patients who underwent an amyloid PET scan in the clinic. And then we were exploring the clinical factors that might be predictive of ordering an amyloid PET scan. We hypothesized that in addition to age and clinical syndrome at diagnosis, certain neuropsychological findings, including impairments on certain memory measures like the CRAD or the presence of rapid forgetting, might be predictive of amyloid PET scan ordering. So the design, from 2016 to 2020, 570 patients were evaluated retrospectively. They had all been seen at the VA Boston Memory Disorders Clinic for concern of cognitive decline. Only 5 patients were excluded due to lack of clinical information not being available in their records, but 565 in total were included since they had at least one evaluation in the clinic. So this is a table of that entire population. Their mean age, the vast majority of them were male. Their years of education, they had a median of 2 years of symptoms duration before they were seen. And their mean MoCA visit was about 20. And then almost 36% had a family history of dementia. So we also learned through looking at these data that our memory disorders population is complex at the VA. And many had a psychiatric history. So almost 40% had a mood disorder or substance use disorder or both. PTSD was quite common. And then traumatic brain injury history of one or more events was quite common. Almost half of our patients had reported this. And then vascular risk factors, including hypertension and hyperlipidemia, were present in nearly 70% of cases. So looking at all of our memory disorders, clinic patients, what percentage of them had certain syndromic diagnoses? So more than half of them ended up getting a diagnosis prior to amyloid PET of mild cognitive impairment. Dementia was also the second most common sort of category at nearly 40%. And then within those suspected syndromes, the Alzheimer's disease was by far the most suspected primary diagnosis, followed by this list of other possible diagnoses. We ended up ordering amyloid PET scans in about a third of patients from the memory disorders clinic. And of that third, 98% of those cases met appropriate use criteria. Only 4 cases didn't fulfill appropriate use criteria. And I believe that those 4 were related to patients having subjective cognitive decline. So no impairments on neuropsychological testing, but the patients themselves felt that their cognition was not at their baseline. And then in some of these cases, there was also a neuropsychiatric or behavioral presentation rather than cognitive. So the patients who got a scan compared to those without a scan tended to be younger. And there were no other significant demographic differences that we could find between the two groups after correcting for multiple comparison. So the vascular risk factors, psychiatric comorbidities were very similar between the two groups. We also found that MCI patients in particular were more likely to get a scan than other groups with other syndromes, which makes sense. And their appropriate use criteria adherence was high. We also found that the suspected primary etiology at the initial visit was Alzheimer's disease, and was more likely to be Alzheimer's disease in those who ended up having an amyloid PET scan, which makes sense as well. We also calculated the appropriate use criteria for those patients who ended up not having an amyloid PET scan. So it's a little hard to think about, but one way of thinking about it is what percentage of these patients would have qualified for an amyloid PET scan if their clinicians wanted to order one. So that was actually pretty high. 64% of patients without an amyloid PET scan could have met criteria. So surprisingly, there were no neuropsychological measures that differed between those who had an amyloid PET scan and those without after we corrected for multiple comparisons. And there were also no structural imaging features on MRI that were predictive of amyloid PET ordering. And I'll just say that these structural imaging features were based on clinician qualitative review using a standardized previously published questionnaire and just during the clinical encounter. So there was no quantitative review of the MRI. So just summarizing the findings from this first study. So younger patients and those that we suspected of Alzheimer's disease at the initial evaluation, these two features were the most predictive of amyloid PET scan ordering. The vast majority of those patients who received an amyloid PET scan met appropriate use criteria. And there was also a majority, almost 64% of those who didn't get an amyloid PET scan could have met criteria for one. And then in the clinical population overall, in the memory disorders clinic, almost 3/4 of the clinical population would meet appropriate use criteria for an amyloid PET scan. We found that the appropriate use criteria adherence was quite high, nearly 98%, and that cognitive and behavioral neurologists tend to use clinical judgment in addition to the appropriate use criteria when ordering amyloid PET in a naturalistic setting. So summary and implications based on prior literature. So as stated before, this was the first naturalistic study of amyloid PET ordering in a clinical practice. We can compare this study to the IDEA study, which was published in 2019. It was a multi-site longitudinal study looking at diagnostic certainty and management before and after PET. And among the MCI and dementia patients with an unclear diagnosis, amyloid PET was associated with management changes at follow-up. And we'll talk a little bit about in the next study that we did about how our amyloid PETs affected management. There was another similar study called the ABIDE study in the Netherlands, published in 2019, where they used their entire memory disorders clinical population and they had them all receive amyloid PETs. So they didn't really implement the appropriate use criteria, but they found that about 50% of their patients would have met appropriate use criteria. Despite not using the appropriate use criteria, they found that those with and without appropriate use criteria consistency both benefited in terms of diagnostic and management changes before and after having the PET scan. But this study was limited by no longitudinal outcome data. So our conclusions from our data were that revisiting the appropriate use criteria would be appropriate in light of our findings, as well as considering patients that had a primarily neuropsychiatric presentation initially rather than cognitive. And then we also talked about the appropriate use of amyloid PET scans in the aducanumab era. So moving on to the next project using this database. So we were looking at the consequences of amyloid PET ordering for clinical care and management of these patients. It had the same design. We used a retrospective study. We wanted to characterize the clinical impact of amyloid PET in the follow-up of patients by comparing the differences in clinical management within a 2-year period of follow-up for these patients who had an amyloid PET scan versus those who'd never got an amyloid PET scan. So the baseline demographics of the population were identical. It was out of 565 patients. And then just to review, there was a high rate of TBI and psychiatric disorders, the same rates in this study. And then the vascular risk factors were present to the same degree. Mild cognitive impairment was the suspected cognitive syndrome in over half of cases, and Alzheimer's disease was the suspected primary diagnosis in the majority of patients. So we found that most amyloid PET scans were being ordered early on in care, either after the first or the second visit. And only 36.5% of the studies ordered ended up being positive. So the majority were negative studies. We did find that amyloid PET scans were associated with diagnostic change. So when ordered, regardless of the result, positive or negative, the amyloid PET scan resulted in a change of diagnosis in 84 cases, or more than half of cases. But negative PET scans in particular were associated with a higher frequency of change in diagnosis rather than positive results. And then we did this before and after controlling for age, the diagnostic impression in terms of etiology and baseline cognitive syndrome. So having a PET scan as part of the initial workup was associated with a longer overall time of being followed in the clinic. It was associated with decreased variability in the etiology at follow-up, and then was also associated with social work referrals. But a positive PET scan in particular was associated with fewer additional diagnostic tests at follow-up, less variability at follow-up and diagnosis, fewer additional studies performed at follow-up, and a greater likelihood overall of cholinesterase inhibitor prescription. More social work referrals were also ordered, and more research and clinical trials referrals were made. So putting these results in context with the prior literature, including the IDEA study. So the IDEA study was the largest prospective study of the clinical impact of amyloid PET. And in that study, 61% of the amyloid PET scans were positive, just to contrast with our number of 40%. And in other studies, the range of positive scans can be between 49 and 64%. The IDEA study reported a 43% change in the rate of AD medications used and a 50% decrease in diagnostic uncertainty and a 4% reduction in clinical trials referrals. So our current study differed in that it was a naturalistic ordering study with a follow-up over a 2-year time period. only 37% of our PET scans were positive, and our positive PET scans were associated with fewer additional tests, which is relatively expected. We also found less diagnostic variability at follow-up, which would be expected, and more prescription of donepezil and cholinesterase inhibitors in general, and more clinical trials referrals. So conclusions and takeaways is that our veteran population is medically complex with high rates of PTSD and other mental health issues like TBI. So that might be a difference for why our amyloid PET positivity rates are relatively lower compared to other studies. And we think that maybe amyloid PETs are mainly being used in our clinic to rule out Alzheimer's disease in clinically complex patients. Limitations of this study and areas for future study include looking at quality of life measures in terms of the impact of amyloid PET on patients' lives, looking at prognostic counseling resulting from the amyloid PET disclosure. And we didn't directly measure any change in diagnostic certainty. We just measured this by reviewing medical charts. Another future area of study could be looking at similar outcomes after tau PET imaging, which we hope to be able to get clinically in the near future. So overall, we think we're ordering an appropriate number of amyloid PET studies in the memory disorders clinic. We could be ordering even more and still be consistent with the appropriate use criteria. We think the appropriate use criteria for amyloid PET need refinement, especially in the aducanumab era. We're often using the studies to rule out Alzheimer's disease rather than rule in. And we do think it is impacting clinical care and management of our patients. We think these results have implications for policy decisions and reimbursement of amyloid PET scans beyond the VA environment. So I just want to thank everyone in our group at the VA, particularly Dr. Ana Vives Rodriguez, who conceived of this project as a fellow and has really led it in our group. She's the first author on several publications that are currently under review. And then everyone else listed here really contributed quite a lot. So thank you all for your attention, and we can take any questions.
Thank you, Kate, so much for presenting. Again, if anyone has any questions, we'll give the opportunity for anyone to ask questions now. You can put it in the chat, or you can unmute yourself and go ahead and ask your question.